Welcome to the Ross University School of Medicine Procedural Skills Tracheal Intubation Lecture Presentation. I'm Dr. Brenton Otey, and I will be guiding you through this lecture today. Let's get started by discussing the objectives. We want to introduce students to the various components of tracheal intubation. We're going to discuss the design and function of the laryngoscope, provide training for the technique of curved and straight blade laryngoscopy, and of course discuss how to confirm proper placement and proper post-insertion management. Let's get started. We're going to start by discussing the indications for tracheal intubation. Those include acute respiratory failure, inadequate oxygenation or ventilation in a patient, airway protection in a patient with altered mental status, and of course in the perioperative setting, patients receiving general anesthesia, surgery involving or adjacent to the airway, unconscious patients requiring airway protection, and surgery involving unusual positioning. Now, let's discuss some of the contraindications. There's absolute and relative. There are very few absolute contraindications to tracheal intubation, but some of those include supraglottic or glottic pathology that precludes placement of an endotracheal tube, also known as an ETT, through the glottis. For relative contraindications, these are contraindications to tracheal intubation, which involve potential difficulties performing the procedures. Such difficulties may be related to anatomic features, injuries, or illness. Here are some examples, just showing you the anatomy that you should be familiar with. This is a diagram of the oral cavity. Some more anatomy just to get you more familiar with the anatomical structures. This is a diagram of the laryngeal inlet. This is a superior view of the laryngeal introitus. So just to note the epiglottis, just so you can kind of recognize these structures when you're preparing to intubate a patient. Now let's discuss preparation. Be careful when preparing for direct laryngoscopy, and tracheal intubation is essential. Have a mental or written checklist for the necessary tools and steps. Essential preparations include the following: assessing the patient's airway when feasible, looking for traits associated with potential difficulty, pre-oxygenating the patient whenever possible, the placement of a suction device, preferably fitted with a tonsil-type tip and a bag valve mask at the bedside, attaching monitoring devices such as BP cuff, the pulse ox, and other cardiac instruments of monitoring, establishing IV access, and preparing necessary medications for rapid sequence intubation, including an induction agent and a neuromuscular blocking agent, and any desired adjuncts, such as pretreatment medications for awake intubation. Fatiguing patients may require blood pressure support once rapid sequence intubation medications are given. Now, you want to gather the tools and materials. These will include your oral and nasal airways, laryngoscope handle and assorted blades, the endotracheal tubes and a stylet, which include the ETTs one size larger and one size smaller than the one necessary for the patient, a 10 milliliter syringe, adjunct airway management devices. This would be the ETT introducer, also known as a bougie, which we will talk about a little bit later on, a rescue airway such as a laryngeal mask airway, and the entitled CO2 monitor. And here's just an image just to kind of show you of all the different materials that you'll be needing during this process. A good mnemonic that we use to help practitioners remember the tools and steps for intubation: STOP-MAID. So suction, your tools for intubation, your oxygen, positioning of the patient, your monitors, an assistant for the ambu bag with the face mask, the airway devices, etc., intravenous access, and then of course drugs for pretreatment. Now, let's discuss the laryngoscope design. It's basically two components. There's the blades, which is the flat element, also known as the spatula, and the vertical element, which is the flange. The McIntosh blade is curved, while the Miller blade is straight, and those are the two most often used. There's a light source as well. A typical laryngoscope blade emits light near the distal tip from a bulb or a fiber optic bundle. The blades are used to displace the mandible, tongue, epiglottis, and any other soft tissue out of the line of sight of the laryngoscopist to expose the glottic opening. And then, of course, pictured here is a laryngoscope. Here's more examples. On the left, we have the Miller blades, which are straight, and then on the right, we have the curved McIntosh laryngoscope blades, with the light source in the middle. Now, let's talk about the laryngoscope technique. There's 5 components that we're going to cover in this presentation. So let's start with key points. The critical step in direct laryngoscopy is to locate the epiglottis. The best ways to improve limited laryngeal view include increasing the elevation of the patient's head and flexion of their cervical spine, and to perform the bimanual laryngoscopy by manipulating the epiglottis with a laryngoscope and the glottis with the right hand. The bimanual laryngoscopy should be performed routinely. It involves moving the thyroid cartilage, not the cricoid, with the right hand, helping to bring the glottis into view. Also, be prepared for unanticipated difficulty. Overview. We want to assess the airway of the patient using the Lemon mnemonic. Look, evaluate using the 3-2-1 rule. This aspect of airway education involves 3 measurements: the distance between the upper and lower incisors, the distance between the hyoid bone and the chin, and the distance from the thyroid cartilage to the floor of the mouth. We also want to get a Mallampati score, as you can see in the image at the top, which kind of determines how clear the oral cavity is. Look for obstruction, obesity, and check the patient's neck mobility. For a general assessment, we need to look at the level of distress of the patient and also the level of their consciousness. Medication choice, and we also want to make sure that we have our equipment set up and ready to go. For the overview continued, we're going to obtain assistance, prepare our equipment, our monitors, our medication, assess, pre-oxygenate, and position the patient, deflect the tongue and soft tissues out of the line of sight, locate the epiglottis, identify and optimize the view, insert the tracheal tube, confirm tube positioning using the CO2 detection, a physical exam, and a chest x-ray, secure the tracheal tube, set parameters for tracheal intubation, and provide sedation and analgesia as needed. So these are the basic steps for performing a direct laryngoscopy and tracheal intubation. Also, keep in mind that head elevation and neck flexion are absolutely not performed when cervical spine precautions are necessary. We will go into detail regarding these steps throughout the rest of this lecture. For positioning the patient, we want to make sure that elevate the patient's head by approximately 5 to 7 centimeters. This provides a sound starting position for experienced airway managers performing a direct laryngoscopy on patients with no predictors of difficult intubation. Again, I cannot stress enough, do not manipulate the head and neck in a patient with a suspected cervical spine injury, as this could further exacerbate the injury. For blade insertion, we're going to use the scissor technique, which holds the tips of the thumb and the middle finger of the right hand together. We're going to insert them between the upper and lower incisors and scissor them past one another by flexing each digit. An alternative method of opening the mouth involves pushing the occiput with the right hand, thereby extending the neck and changing the angle of insertion. So we open the mouth, let's optimize our view. Some general guidance: the following techniques can be used to improve an inadequate view of the glottis. Make sure the tip of the laryngoscope blade is correctly seated in the vallicula when performing the curved blade laryngoscopy. Ensure the tongue is well controlled and completely contained within the left side of the mouth. Avoid the common tendency to extend the neck, as extending the neck generally does not improve the view. We're going to lift the head and flex the neck. An inadequate view of the glottis can often be corrected by elevating the patient's head. You can also use the bimanual laryngoscopy, which lifting a properly positioned laryngoscope while it raises the epiglottis and helps to expose the glottis, also elevates the interior larynx. This essential maneuver, called the bimanual laryngoscopy by some and external laryngeal manipulation by others, improves the glottic view in more than 50% of patients with inadequate initial views. And then, of course, external manipulation of the glottis, performed by pushing and manipulating the thyroid cartilage with the right hand. This counteracts the lifting forces of the laryngoscope, allowing the laryngeal structures to be brought down into view. Now, let's talk about the specifics of the curved blade laryngoscopy. We're going to open the mouth sufficiently to allow blade insertion without traumatizing the teeth, insert the blade, and control the tongue. Carefully advance the blade towards the epiglottis in a controlled manner, gently lifting the blade tip every few centimeters. Advance the tip of the blade into the vallicula, the recess between the base of the tongue and the epiglottis. Identify the best spot for elevating the epiglottis. Lift the laryngoscope in the direction of the handle, thereby exposing the glottis. Do not lever back on the teeth with the laryngoscope handle, as this could cause damage to the patient's teeth. Optimize the glottic view as needed with external laryngeal manipulation, head elevation, and neck flexion, as mentioned previously. And then on the pictures here, left is using the curved blade technique as we're discussing right now, and the right would be with the straight blade technique, which we'll go into detail later. Finally, place the tracheal tube. Inflate the balloon with the 10 milliliter syringe and secure your ET tube to the patient's face. Now let's discuss straight blade laryngoscopy. For the straight blade technique, a straight blade may be inserted to the right of the tongue, paraglossal technique, or in the midline. Introduce the blade into the mouth to the right of the tongue, between the tongue and the patient's right lower molars. Advance the tip of the blade along the tongue into the groove between the tongue and the tonsillar pillar. In a controlled and deliberate manner, continue to advance the blade tip while looking for the epiglottis. Use the lateral and interior pressure to keep the tongue displaced to the left. Once the epiglottis is identified, advance the tip of the blade posterior to the epiglottis and into the laryngeal inlet. Use the blade tip to lift the epiglottis anteriorly upwards in a supine patient, which would expose the vocal cords. Optimize the glottic view as needed with external laryngeal manipulation, head elevation, and neck flexion. Lastly, insert the tracheal tube and inflate the balloon with the 10 milliliter syringe and secure your ET tube to the patient's face. Now, we mentioned the tracheal tube introducer previously. Let's go into a little bit more here, also known as the gum elastic bougie or simply the bougie. When the view of the glottis is limited, the introducer can be placed in the trachea using tactile and limited visual cues, and then a tracheal tube can then be inserted over it, which makes this easier. Effective and an important adjunct to direct laryngoscopy and difficult airway management. This can be used when the view of the glottis is limited. Confirmation of proper endotracheal tube placement is crucial. Unrecognized esophageal intubation leads to devastating complications. Once the endotracheal tube is placed, its location in the trachea must be confirmed immediately. And there are several methods to do this. We can check using the end-tidal carbon dioxide, using the quantitative capnography, which is the most accurate means of confirming proper ETT placement in the non-cardiac arrest patient. There are clinical findings by listening to equal breath sounds in both axillae. No breath sounds should be appreciable over the epigastrium. Other findings consistent with tracheal placement include rise of the chest wall with positive pressure ventilation and mist in the ETT with exhalation. We also want to make sure that the depth of the tracheal tube insertion is accurate. In women, Endotracheal tubes should be inserted to a depth of 20 to 21 centimeters, while in men, the appropriate depth is around 22 to 23 centimeters. We prefer to use the teeth or gums as the benchmark for insertion depth, rather than the lips, because they are fixed landmarks. Proper post-intubation management includes securing the tube after it has been confirmed to be in the correct location with a tube holder and tape, as you can see pictured here. Some complications include direct, blunt, penetrating trauma, potentially cervical spinal cord injuries in susceptible patients, dislocation of the TMJ, and there are some non-traumatic complications as well, including aspiration, bronchospasm, hypoxic injury from prolonged attempts at intubation, esophageal intubation, and barotrauma. Lastly, some long-term complications of tracheal intubation include laryngomalacia, tracheomalacia, and laryngeal stenosis secondary to trauma to the airway.